Uh, Dr. Nimitha is Dr. Bindu's student, and I have been seeing her since she was a kid. Probably from school days, I have been seeing her. She graduated, and then post-graduation, now she is as a glaucoma specialist. It's wonderful to see you, Dr. Nimitha.
She
So-
won last year's award also in glaucoma paper.
Wonderful. Congratulations.
Thank you.
Super. So that is my introduction to you.
Thank you so
So
much,
kid
sir.
to a glaucoma specialist. Nice to see you here. So I'm becoming old. Thank you.
Good morning. Today I'll be talking on MICROPULSE and CYCLO G6 laser. So MICROPULSE, it's a sub-cyclo photocoagulation. It has been marketed as a replacement to trabeculectomy, and the probe cost is 25,000 and it requires multiple treatment. And it is a non-invasive IOP lowering therapy with excellent safety and efficacy, and it qualifies as a primary therapy, especially during pandemic. There are two machines, that is the Iridex as well as the Contel machine, which provides this laser. The 810 diode laser, it is of continuous beam. In MICROPULSE, it makes it into on and off, that is repetitive on and off pulses. And this prevents the collateral damage to the surrounding tissue. It also acts at the subthreshold cell damage, and it reduces, by reducing the aqueous humor production, and also it increases the uveoscleral outflow and has a pilocarpine-like effect also. So this is a picture. Basically, it affects the pigmented ciliary epithelium. There are two probes. The newer probe, that is, it has a bunny-like ears, which is projected towards the limbus, and it has a better viewing and can be used in sunken eyes, and it has an intuitive probe orientation and better light coupling. So before doing a MICROPULSE, we have to do a transillumination. That is clear transillumination I've done here. And it should be done mostly in cases of congenital glaucoma, high myopia, and wherever there is distortion of the limbal anatomy secondary to previous surgery. And the G probe placement should be 1.2 millimeter from the corneoscleral limbus. And the G probe is designed in such a way that it delivers more posterior, the energy posteriorly, even though there is posterior than the fiber optic protrusion. So after taking an informed consent, the Iridex machine duration power is 2000 seconds, and the duration is 80 seconds for each quadrant. The probe is held perpendicular to the limbus, and it is just swept across, avoiding the 3 o'clock and 9 o'clock position. So the success of MICROPULSE, it basically depends on the energy. In various studies, it has been shown that the energy level varies from 1600 millivolt to 2500 millivolt. In retreatment eyes, it is about 3000 millivolt. So as the energy increases, the complication rate also increases. So the main success depends upon the sweep velocity. In this article by Grippo et al., it shows they have shown that if there is a lower sweep velocity, more energy is being delivered to the tissue. And also the location of the ciliary body is important, and the degree of pigmentation, that is, higher the pigmentation, lesser energy is required of the ciliary body. The revised MP3 probe is same like the previous MP3 probe, with the same duration, cycle, and power. This is a study of, this is a multicentric study where 167 eyes were studied, and in this study, nearly half the patients required additional intervention, And also there was complications like decreased visual acuity and mydriasis was also seen. This is a study conducted by Lee et al. In pediatric group. He compared the pediatric versus the adult group, and he found out that in pediatric the efficacy of micropulse is lower, mainly due to because the children's ciliary body will regenerate rapidly. The different location, the ciliary body is more anteriorly located, and the diversity of the diseases. He had chosen multiple various etiological diseases. In advanced glaucoma, a study was conducted, and they had found that in 1 year, the success rate was 36.4. In 3 years, it reduced to 32. And the median survival time of micropulse was 9 months. And phthisis bulbi was seen in 7 eyes, and prolonged hypotony was seen in 1 eye. This is an article of a micropulse done in eye syndrome, where the pre-op IOP at the end of 8 months from 23 it had reduced to 10, and they had used a 2000 watt power with 90 seconds done. There are other techniques to improve the micropulse efficacy. One is the MP3 plus, where micropulse is being done. Along with it, 16 additional spots were given. And this is another technique, that is CYCLO mix procedure, where superiorly they have done micropulse and inferiorly they have done G6 procedure. In these two cases, there was IOP lowering and no severe complications were reported. Basically, when we give a peribulbar block, if there's a subconjunctival hemorrhage, when we do a micropulse, there can be a thermocoagulation of tissue and conjunctival scar formation. So better to avoid micropulse in subconjunctival hemorrhage patients. And if there is severe OSD, it can result in neurotrophic keratitis. And we have to avoid 3 o'clock and 9 o'clock, as it can damage the perilimbal neural plexus. And also you have to check the corneal sensation. In this study, this patient had neurotrophic keratitis, and later it was corrected he required a tarsography. This is an article where the patient post-MP laser had developed suprachoroidal hemorrhage and hypotony and increased inflammation. So we had done micropulse in 17 patients. So except in early glaucoma, rest all patients, the medications were not altered, and 4 patients required a repeat procedure, and the complications were epithelial defect and decreased visual acuity. So to summarize, micropulse can be used as an adjunctive procedure for temporary IOP reduction, and the patients may require reoperation, and there are significant complications like loss of visual acuity, prolonged hypotony, and phthisis, which is less compared to CYCLO G6 and cryotherapy. Next, I'll be talking on cyclophotocoagulation, where we use most commonly diode. Here, the continuous wave, it mainly damages the pars plicata and thereby decreasing the aqueous production. So there are various indications of CYCLO G6. Mainly it's done in patients' painful blind eyes with poor visual acuity. So the fiber optic transmission, it has a protrusion of 0.7 millimeter from the limbus, and the power duration is 1300 to 2000 milliwatt, with a duration of 1.5 to 3.5 seconds, and we need to titrate the power based on the pop sound, and 180 degrees basically treated. So after giving peribulbar anesthesia and lidocaine jellies put, the probe is held perpendicular to the limbus, and superior and inferior quadrants are given, avoiding 3 o'clock and 9 o'clock position. So the cost, the practical considerations is that the cost of the probe is 25,000. We have to avoid 3 o'clock and 9 o'clock position because of the position of the ciliary nerves, and also you should avoid areas of increased conjunctival pigmentation and scleral thinning. And when reusing the probe, you have to clean the probe meticulously. Complications like pain, initially high IOP, hypotony, thysis bulbi, decreased vision, inflammation and hyphema, sympathetic ophthalmia, conjunctival and scleral burn, scleral thinning and staphyloma are noted. So this is an article where there was a scleral perforation seen after CYCLO G6. It's basically due to the faulty laser probe, and there was a debris at the probe, and it could happen due to scleral thinning also, and you should avoid areas of localized pigmentation and scarring. So this is our results, where we had done CYCLO G6 in 110 patients, and for 93.6 patients we had done it for pain relief, and most common etiology was the neovascular glaucoma. The parameters we had set was 3000 milliwatt and power was 1000 millisecond, and basically we had a 20.7 decrease of IOP, which is significant, but the number of medications was not significant, which was preoperatively it was 3.03 and it reduced to 2.42. So the complications were mainly decreased visual acuity. 2 patients had phthisis, that is because they were done on, they had scleral thinning. So to summarize, basically the cost, so when the cost is 25,000, so we have to pool the patients, and also the probe, it lasts for 90 minutes only. So pool the patients while doing the CYCLO G6 procedure. And it's a well-tolerated procedure with maximum IOP lowering effect, and complications like pain, decreased vision and phthisis have been reported.
Thank you, Nimitha. I think we are short of time. I just have